Hello and welcome to our second ever live stream to It's All Happening at UTAS. I'm Dr. Jamie Chapman. Welcome along. Hopefully we've got people out there. So if you're there, please type in the chat, say g'day so we know we're not talking to the ether. We see Skeens there. Thanks very much for coming along. So unfortunately, our first stream didn't record. I didn't hit enough buttons apparently, so unfortunately it didn't record. So that's lost to posterity. So for the few of you who actually came along, that was good for you. But unfortunately for everyone else, they weren't able to review it. So we're doing this sort of make-up stream. We're not going to be repeating the same things unless you specifically ask for it. We're giving another opportunity for people to come in and ask questions. This one will be recorded. I can see it's recording now. So hopefully we'll have an opportunity to review it in your own time again if you need to. Nish, thanks very much for coming along. Kylie, hello. Aidan, Average Joe, MN525, welcome along. Harmonia, thanks for saying g'day. I really appreciate you coming along and saying hello. So Dr. James Crane and I are both here. We're going to help to answer any questions which you may have. I have had a question pop up on our learning management system, which we call Milo. Isabella, hey, g'day. And that is in relation to meiosis and comparing meiosis between males and females. So we're going to start off with that, and then if you have other questions along the way, James and I can swap places. If you've got a question about physiology of any of the systems, neuroendocrine, cardiovascular systems, reproductive, obviously I can answer, James can answer just as well, but I taught it. So Kylie, hi Emery, thanks very much for coming along, glad to see you here. All right, so we are going to switch over to our drawing tool. So as I mentioned, we're going to be starting off by having a look at meiosis between males and females. Of course, I'm going to take off my glasses because I see better in the short distance without my glasses. We're going to have a look at the meiosis between males and females. Of course, in males, meiosis is known as spermatogenesis. Okay, spermatogenesis, and in females, it's known as oogenesis. So of course, there's a number of significant differences between males and females in regard to meiosis. I suppose the timing is the biggest issue, biggest difference between the two. So if we think about timing between the start of spermatogenesis versus oogenesis, then it begins in males at puberty. So we don't actually begin meiosis within males. So if we do the little drawing here, and then of course oogenesis in people with ovaries. Whereas in females, timing actually begins before birth. So we have all of those oogonia within the ovaries during development, while the developing fetus is within her mum. And those oogonia all begin meiosis 1, and they all become primary oocytes. Now all of these primary oocytes are actually arrested at prophase 1. Okay, so remember we have those different stages of meiosis. We have prophase, metaphase, anaphase, and telophase. And that first meiotic division, we give them the term 1. So prophase 1, metaphase 1, anaphase 1, telophase 1. Then we end up with 2 cells, each with 23 chromosomes, but of the double chromatid type of chromosomes. And then they move into the second meiotic division. And so prophase 2, metaphase 2, anaphase 2, telophase 2, and we end up with what should be in general terms of 4 cells. We know things are a little bit different in the oocyte. In spermatogenesis, we do end up with 4 cells which eventually go on to develop into spermatozoa. Now in oogenesis, the oogenesis begins before birth, within the ovaries, where all of the oogonia begin meiosis 1 to become primary oocytes, so that by the time at birth, there's only primary oocytes within the ovary. So we have no more stem cells left within the ovary to actually produce new oogonia or new oocytes. So a person with ovaries is born with all of the oocytes within her ovaries that she's ever going to have, or they're ever going to have. Sorry, I'm still getting used to the terminology when I'm trying to be a bit more inclusive, so please bear with me if I make a few errors along the way. So, whereas puberty, entering into meiosis doesn't begin until puberty. So we have our spermatogonia, and then they become primary spermatocytes once they actually enter into meiosis 1. And then they actually produce 2 secondary spermatocytes. And they enter into meiosis 2 almost immediately. So they're only there for a very short time within the seminiferous tubules. And so from our 2 secondary spermatocytes, my head is in the way. So let's go to screen only. Secondary spermatocytes there. So meiosis 2, and from our secondary spermatocytes, because there's 2 cells, each of those cells produces another 2 spermatids. So we actually get spermatids. So we have 4 of those. So there's 2, we have 1, and of course we start off with 1 spermatogonium. So 1 spermatogonium enters into meiosis 1, becomes a primary spermatocyte, then that undergoes meiosis 1, producing 2 cells, 2 secondary spermatocytes. They immediately enter into meiosis 2, and then they produce 4 spermatids. Now these are N, this is N, 2N, and these are 2N, meaning that these have 46 chromosomes. The primary spermatocytes are basically just modified spermatogonia, so they also have 46 chromosomes. The difference being that those chromosomes have replicated immediately prior to the spermatocytes entering into meiosis 1. So that spermatocyte then undergoes meiosis 1, producing 2 cells, each with 23 chromosomes, but they're of the double chromatid type. Amanda's here. Hello, Amanda. Everyone, Amanda's in the chat there. Amanda's a lecturer in anatomy from the University of Western Australia. So she's a mate, and she's come along to provide some support. So thanks very much for coming along and saying g'day. So we've got our 2 secondary spermatocytes. They immediately enter into meiosis 2, and they produce 4 spermatids, each with a single chromatid type of chromosome. These then undergo spermiogenesis rather than spermatogenesis, which is a morphological transformation from these round cells here to the more mature looking sperm. And so they produce spermatozoa. Okay, so that's spermatogenesis, and as I say, this basically takes place from puberty until death. So males produce sperm from puberty until they die because they have the spermatogonia, whereas females, because all of their oogonia enter into meiosis 1 and become primary oocytes, there's no more oogonia to make new oocytes. So this is the way the oocytes stay. Rested at prophase 1, primary oocytes are rested at prophase 1 within the ovaries. Now, once a month after puberty, following an LH surge, 1 oocyte gets stimulated to resume meiosis 1 to form a secondary oocyte, which is arrested at metaphase 2. and it also spits out what's known as a first polar body. Now, the first polar body goes on to degenerate. Oh, I'm running out of room. So the first polar body goes on to degenerate, and so it's at this point that ovulation takes place. Okay, so ovulation takes place here, and so once a month this happens. We get stimulation of a primary oocyte to resume meiosis, and complete meiosis 1 to become a secondary oocyte. Immediately enters into meiosis 2, becomes arrested at metaphase 2, and it stops there. It spits out a first polar body with 23 chromosomes, which goes on to degenerate. Now, this is the way it'll stay unless fertilization takes place. Now, if fertilization takes place, then this binding of the sperm to the oocyte cell membrane stimulates a resumption of meiosis. We end up with a fertilized oocyte and a second polar body. And that also goes on to degenerate like the first polar body. Okay, so the major differences, of course, between males and females, obviously the timing. So it begins before birth in females, whereas it doesn't begin until puberty in males. It arrests firstly at prophase 1 for the primary oocytes, and then at metaphase 2 just prior to ovulation and then after ovulation. And it may not continue, it may not actually complete unless fertilization takes place. The other major difference is, of course, this uneven cell division. So whereas we start with one spermatogonium producing one primary spermatocyte, which then produces 2 secondary spermatocytes producing 4 spermatids and then 4 spermatozoa. So we have 4 viable cells. From our original oligonium, we have 1 primary oocyte. It produces 1 viable secondary oocyte and a non-viable cell in the form of a first polar body, which goes on to degenerate. And then following fertilization, we get a second oocyte, or the same oocyte, I suppose, being formed, and then a second non-viable cell, which is the second polar body, which goes on to degenerate. Just be aware, some textbooks actually say that the first polar body actually divides into 2 cells, but that's actually not true. It actually degenerates, and I think the early histologists, when they were describing it, actually saw the degeneration of the first polar body and mistook it for cell division. The polar bodies actually don't have the machinery within their cytoplasm to actually bring about that sort of division, so it's actually degeneration that's taking place. All right, in males, the major difference, Skeen. In the case of fraternal twins, absolutely. What happens is that the 2 oocytes are fertilized independently through 2 sperm. Now, if you get more than 1 sperm fertilizing an egg, it's actually a fatal event for that embryo because you have too many chromosomes. So you get 23 chromosomes from the oocyte, you get 23 chromosomes from the sperm, and obviously if you add another 23, you've got too many chromosomes, and then eventually that embryo won't be viable and will be lost. So if we're talking about identical twins, what happens is we get 1 sperm fertilizing 1 egg, we get embryonic development. Now, at some stage during embryonic development, those cells undergo differentiation. Then when that cell, before it actually differentiates and has a true pathway to either become like a cell of the placenta or one of the embryonic cells, one of those buds off and then grows like a second individual. So that second individual is genetically identical, but then once it actually buds off, and sometimes it can keep the same placenta or it may form its own placenta, then it has actually a separate environmental growth. It gets different hormones, it gets different levels of nutrients and toxins and so on. And so actually there's a nature versus nurture change here once we actually get separation. So genetically, identical twins are genetically identical, but their environment within which they grow up, and even in that small uterus, can be different, and they can bring about different changes. So much so that identical twins actually have different fingerprints from each other. So genetically, fingerprints are actually derived, have a common core genetic component in terms of this finger's going to have a swirl, or this finger's going to have an arch, but the actual final result is brought about by environmental factors during development. And so identical twins actually have different fingerprints from each other. Hopefully that helps answer your question. You got a little bit more than you probably asked for. So spermatogenesis, the major difference being, of course, that one thing which I haven't mentioned here, when these cells divide, it's an incomplete cytokinesis. So the cells are actually held together by a little intracellular bridge. So that this is thought to help maintain release of X and Y bearing sperm at the relative same time. So these intracellular bridges last right up until we get this spermiogenesis, and then they break and eventually they're released. Great. All right. Does anyone have any questions about meiosis there? Anything there that you want to sort of further clarification on? Or does anyone have any other questions which you'd like us to start discussing? Otherwise, I think James had something to talk about regarding the up to 20 primordial follicles mature into primary follicles. Some primary follicles mature into secondary follicles. Yeah, and then in order for the secondary follicles to continue development, we actually need FSH. So that development that Amanda's just talked about in the chat, that primordial follicles becoming a primary follicle and then primary follicle becoming a secondary follicle and developing that follicular antrum, that's actually independent of FSH and LH. It's only after we get puberty and we get those levels of FSH being at significant levels that we get capture or cyclic recruitment of those secondary follicles, and they go on to one becoming the dominant follicle that'll be ovulated. Now, as we've mentioned about dichrotic twins, Jamie, could you explain the involvement of the parasympathetic systems in an erection? Sure, cooler zip. I think I used, and I apologise for anyone who's not used to my language. There's a very gross and broad way to describe it. Parasympathetic gets it up and sympathetic gets it out. So let's clear this. So if we think about the penis, so we're going to do a cross section of the penis here. We have two upper erectile tissue masses in the penis, like this, and then we have a lower erectile tissue masses. So you actually get a little bit of a grumpy looking monster kind of appearance. So here, down here, this is the corpus spongiosum. So this is the urethra. Point and shoot, Amanda, well done. So here we've got our blood vessels, these deep arteries, and then out here we actually have the vein. So these are the corpus cavernosa. So this is corpus cavernosum, or plural is corpus cavernosum, so corpus cavernosum. This is the vein, and then this is the deep artery. Okay, and so throughout here, we actually have, click OK, we have lots of vascular sinuses in this region. And we also have some down here, but not as many as in the corpus cavernosum. Okay, so what happens is with the erection, the male gets aroused somehow. Sight, smell, taste, vision particularly, sees arousing images, and this stimulates his central nervous system, particularly the parasympathetic nervous system. Okay, and so that sends impulses to the blood vessels within these cavernous venous sinuses. Now, normally these are under sympathetic control and they're under vasoconstriction. So they're actually constricted here, and not a lot of blood flows into these blood vessels here, these vascular lacunae, so these vascular. There's a U there. Believe me, there's a U there. So the parasympathetic nervous system, what it does is actually cause vasodilation of the smooth muscle within these blood vessels here. So not only here, but also within the deep artery. So we're actually getting more blood flow happening, filling these vascular spaces. Okay, so the parasympathetic nervous system causes vasodilation of the deep artery of the penis within the corpus cavernosum, and then also within these vascular lacunae. So that then enables the blood to expand and fill these spaces. So as these corpus cavernosa begin to expand, they increase in size, and then eventually what happens is they begin to actually constrict the venous flow, so that blood keeps continuing to fill these vascular sinuses, and then because there's a very dense connective tissue layer around the outside here, that blood becomes compacted within the corpus cavernosa, and therefore erection takes place. So these expand, they impede the venous flow, so blood keeps coming out, less blood returns, and so therefore an erection it takes place. Now, does testosterone have any influence to spermatogenesis? So this is sort of going back, I suppose. Let me just finish this and we'll talk about that question. So that causes an erection. Now, in terms of ejaculation, which I know you haven't asked about, there's sort of two phases. We have an emission phase and we have an ejection phase. The emission phase is about moving all the fluids into the ducts ready for the ejection phase. The emission phase is brought about by the sympathetic nervous system. So here, brings about the emission phase. So it moves all the fluids, it moves the sperm, it moves the seminal fluid, and it moves the prostatic fluid into the urethra, ready for ejaculation. Now the ejection phase is actually brought about by a lumbar reflex in the spinal cord. It causes contraction of the muscles around, forceful contraction of the muscles around the ductus deferens, around the bulbospongiosus and the cavernosus muscle, and that causes forceful ejection of the semen from the penis. So because we've got this eventually the sympathetic nervous system being stimulated after ejaculation, this does the reverse of what the parasympathetic nervous system does. It causes constriction of the blood vessels, and therefore the blood flow decreases, and so it begins to decrease in size, venous flow returns, and eventually you end up with the reverse of an erection, which is known as detumescence. Oh, what is the role of autonomic nervous system in the female sexual response, if any? Okay, so we know the autonomic nervous system is responsible for secretions of glands, and for female sexual response, of course, the vagina needs to be lubricated, and it's lubricated by glands near the opening of the vagina called the vestibular glands. the greater vestibular glands, and they lubricate the opening of the vagina. We also get secretions from the cervix as well, helping to lubricate the vagina. So the parasympathetic nervous system is stimulated in females like it is in males. It causes increased blood flow to the genitalia. There are swell bodies or erectile tissues within the genitalia, one within the clitoris, causing the clitoris to increase in size, but also within the labia there's erectile tissue masses, and they help to open up the vagina, exposing the vaginal opening, allowing easier access for penetration by the penis. So we get increase in secretion of the glands near the opening of the vagina to enable for penetration. We get increase in blood flow to the clitoris as well as to the general vulva area, particularly the labia, and then that causes opening and preparation for penetration. So that's sort of the female equivalent response to sexual arousal. So in males it causes the parasympathetic nervous system to cause an erection, and in females it's about erection as well as lubrication through the secretions of the opening of the vagina. Now we need to go back to, does testosterone have any influence on spermatogenesis? There's a very complicated relationship between testosterone spermatogenesis and the various other hormones there, but particularly testosterone is thought to play a particularly important role in spermiogenesis, that transformation of the round spermatid into the mature sperm. So it's thought to play the major role there. FSH is the particular hormone particularly driving spermatogenesis. So the nurse cells or the Sertoli cells within the testis, within the seminiferous tubules, have receptors for FSH, and that helps to drive spermatogenesis. And then testosterone is thought to help with the final stages of spermatogenesis. Testosterone is also, of course, really important for the maintenance of the accessory sex glands, the prostate gland, the seminal vesicles, and they don't produce seminal fluid at such a rate without that testosterone. Boston Monday, hopefully that helped answer your question about the female sexual response and the autonomic nervous system. Will there be any more of these lectures? Yeah, so our plan is James and I are going to do a weekly live stream for you guys from now on. So we actually have our next one, which will be Thursdays 4 to 5 is our normal time. This time is sort of an extra one to make up for the one which I accidentally didn't record last week. But our plan is to actually have these live streams once a week on Thursdays 4 to 5. Obviously next week we won't do one because you guys are on mid-semester break, but we'll do that the week after. So we'll do one this week again, so we'll have a look at the respiratory system. So we'll sort of try to keep current with the current topics, so you can get a little bit of revision there. Thanks, Boston Monday. I'm glad you helped. Yes, and I can see that James has helped answer the question there. So hopefully that helped to answer everyone's questions about the response of the autonomic nervous system to erection. Is there anything else here? Or do you want to move to the cardiovascular system? Are you any questions on the cardiovascular system that James can take over with? I know we're about halfway through, so if you've got questions there. Otherwise, I think James has something which he's happy to talk to you about with the cardiovascular system, something which he likes. So what I might do is clear this and I'll pass it over to James. And again, if you have any other further questions, I'll be on chat from now on, and James and I can try to help you out. So I'll pass you over.
Right. Hello, everyone. Been sitting in the background watching Jamie do a great job explaining oogenesis and spermatogenesis. So what I thought I'd do, because there doesn't seem to be any questions right at the moment, but I know that in the last lecture we talked about the Wiggers diagram and we went through that and we related that to the cardiovascular cycle. One of the things that I really like to talk to students about when we're going through this is just how simple the cardiovascular system actually is in terms of its physiology, right? So the cardiovascular system is really just, a pump with some tubes stuck on it. And as a result, it obeys all of the laws and the physics associated with a pump with some tubes stuck onto it. And any other time that you've ever kind of played with fluid going through a tube, so water going through a hose, for instance. So one of the things that no doubt they would have discussed with you, and as we were going through this, would have been this formula here, that blood pressure is equal to cardiac output multiplied by total peripheral resistance. Okay, so let's break this down. So what do we mean by total peripheral resistance? What we mean is the resistance to flow of blood through the cardiovascular system, particularly in the systemic circulation, and the resistance that we have to that flow is largely determined by the diameter of the blood vessels. So if we think about this in terms of just sort of water through a tube, and let's say we have water coming through here, which we've turned on a tap and water's moving through here. All right, so we'll have a certain flow of water coming out of this hose. If we then come along, and everyone will have done this at some point, and we pinch this hose, so what we've done is we've decreased the diameter of that hose, and we've created resistance to the flow of that water and the flow of that fluid through the hose. Right? So what is going to be the consequences of that? Well, we'll see that there is less fluid coming through, but as a result, we've still got a certain volume of fluid being forced into the hose, and so we'll see an increase in pressure on this side, right? On this side of the resistance, where the resistance has been applied. And so you can kind of see this here, right? Where if we're looking at the cardiac output, if this is how much we've turned the tap on, and if we keep this cardiac output constant, and then if we increase the resistance to that flow, then we'll see blood pressure increasing. Okay. And conversely, if we decrease the resistance, and if cardiac output stays the same, then we'll see blood pressure decreasing. One of the things that we need to do when we're looking at blood pressure is, and one of the things that organisms need to do is maintain blood pressure, right? So this, if blood pressure drops too low, then we have all sorts of issues maintaining organ function. And, this is no more apparent than in the brain, right? So when we're standing up, obviously we have to resist the force of gravity as well. So we need to maintain a certain blood pressure and a certain flow of blood into the brain in order to make sure that we can keep that organ functioning. I mean, to some extent, when you see blood pressure dropping precipitously, one of the reasons, I like to say that you fall over and you faint and you become horizontal is it's sort of your brain saying, keeping blood flow going up here would be a lot easier if you were laying down. We don't have to worry about dealing with gravity, at least at that point. So if we're talking about blood pressure and cardiac output times total peripheral resistance, now we can sort of look at this cardiac output. So cardiac output is how much blood is coming out of the heart at any one particular point in time. So what that is heart rate, how often the heart is actually pumping, so how often per minute we're actually getting the blood to come out of the heart. And then the other consideration is stroke volume, so how much blood is coming out every time the heart actually beats, right? So together, this combination of heart rate versus stroke volume gives us our measure or contributes to the amount of blood that's coming out of the heart. So this cardiac output is defined by the heart rate and the stroke volume. And when we look at the relationship between cardiac output and total peripheral resistance, when the resistance goes up, we see an increase in blood pressure. And when the resistance goes down, we see a decrease in blood pressure for a given cardiac output. The important consideration here is that and this is what I find absolutely amazing about this, is there are three things. When you're looking at the physiology of the cardiovascular system and how the cardiovascular system is going to work and attempt to maintain blood pressure, it has three levers that it can pull. It has only three things that it can play around with. It can alter the resistance to blood flow by changing the diameter of the blood vessels by vasodilation and vasoconstriction, which Jamie talked about a little bit when we were talking about erection function. And we also can change how much blood is actually coming out of the heart in terms of this cardiac output. So what we'll do is we'll have a bit of a chat about how those things might change in various different situations. So for instance, exercise, etc. So I noticed that there's a question here by Spaghetti Bolognese, which is a great name. What effect does posture have on systolic and diastolic blood pressure? Well, so that's actually probably a really good one, right? So if we're looking at moving from a reclining position or a laying down position and moving to a standing up, an upright position, then one of the things that we know is that we're going to have gravity pulling the blood down towards your feet, right? And so we're going to have a decrease in blood pressure, at least as it's measured by the baroreceptors in the aortic arch, right? And so we're going to see a decrease in blood pressure. So let's say as we stand up, we start to see a decrease in blood pressure. So if we just look at this formula here, if we look at just the three things that we can play around with, how are we going to address that situation? Well, we have three levers that we can pull, right? So we might see, and we will see, a reflex response to increase heart rate, right? We'll see an increased response to increase heart rate, and this will be via a sympathetic nervous system activation. So we'll see a sympathetic nervous system activation. We'll see an increase in heart rate, so the heart will beat more often. And depending on the strength of the stimulus and the strength of the blood pressure response and the change there, we may also see an increase in stroke volume, right? We may see an increased contractility of the heart. We may actually see more blood coming out of the heart with each one of those. At the same time, we will see the sympathetic nervous system, and also there's an endocrine response in there involving vasopressin, otherwise known as ADH, but vasopressin coming out of the hypothalamus, and we'll see an increase in total peripheral resistance. So we'll see a vasoconstriction of vascular beds, particularly in the periphery, in the skin, and in the gut. And what that's going to do is, by increasing heart rate, potentially increasing stroke volume, and increasing total peripheral resistance, by increasing these three factors, we'll see that we'll have increase in blood pressure, right? So we'll definitely be seeing that. So we have, so Jamie's answered that. End diastolic volume affects preload, right? Okay, so end diastolic volume is going to affect preload, which is getting back to that Wiggers diagram that we were talking about. And so the preload is going to increase the stretch on the ventricle. So if we have an increase in preload, which is the amount of blood that's actually coming into the heart, then we'll see an increased stretch on the ventricle. And that increased stretch through a thing called Starling's law of the heart will result in an increased contractility. And this has to do with the position of the thin and the thick filaments within individual sarcomeres inside the myocytes, but it's probably a little bit beyond what we need to go into. One thing we can sort of talk about really quickly here, if we're going to be looking at these three things, and I think this is a really interesting way to sort of examine these three different factors, is to look at the difference in exercising in the cardiovascular response, or at least the blood pressure response, and the cardiovascular attempt to maintain blood pressure, when we're looking at exercising in different temperatures and different ambient temperatures. So if we're exercising in a cold temperature, so down in Hobart here, it's been a bit chilly, as you may have worked out on the news over the last few weeks. So, what is it like exercising in a cold temperature? And what is it that we're actually trying to do? So when we're exercising in a cold temperature, we have a couple of things that we really need to do. First of all, obviously, we need to increase blood supply to muscles so that we can take oxygen and nutrients to the muscles. We can get rid of waste going into away from those muscles as well. But we also, because it's cold, we also have a requirement to sort of maintain our body temperature and make sure that we're not having any really significant issues with body temperature. In a cold environment, it's not terribly difficult to maintain your temperature. You're exercising more, and so you're going to be producing heat. You may just want to mildly limit the amount of heat loss, depending on how vigorously you're exercising. So when we exercise in a cold temperature, we will see a couple of different things. We're going to need to increase our cardiac output. Oh, that's a very big, thick line. We're going to increase our cardiac output to make sure that we're supplying nutrients to our muscles and getting rid of waste. And we will see probably a decrease, potentially, in total peripheral resistance. Maybe not a huge amount, but we would expect to see a little bit of a decrease. And that's because as we're increasing our cardiac output, the other thing that we're trying to do is is to increase the flow of blood into our skeletal muscles, particularly the big muscles. Let's say we're going for a run, particularly into the big muscles of the leg. We're going to see an increased vasodilation, and this could lead to a decrease in total peripheral resistance. We may compensate for that in cold environments, and we have the ability to compensate by that because we're not too concerned about getting rid of heat by increasing the vasoconstriction of vascular beds in the skin and also in the gut and going to the kidneys as well, right? So we have the ability to also increase some of our vascular beds, and as a result, our total peripheral resistance is probably not going to change a huge amount. As a result, we're going to see we desire to increase cardiac output, probably see an increase in heart rate, and we'll see an increase in stroke volume again because of this preload, right? So we're going to see more of that skeletal muscle pump pulling blood back into the right atria and into the right ventricle, and then back into the systemic circulation via the left side of the heart. And so this is going to cause an increase in blood pressure here for us, right? Because of not so much change in total peripheral resistance, but an increase in cardiac output, right? So we would expect to see some increase in blood pressure to some degree in this situation. As I said, the body would tend to try to mitigate that by adjusting total peripheral resistance a little bit. The situation becomes a little bit more complicated though if we consider exercising in hot temperatures, right? So if we're in Queensland in summer where it's hot and it's humid, and so our ability to lose heat through evaporation is significantly compromised because it's just harder to get the water to transfer into the atmosphere. So we struggle to get rid of heat. And so in this situation, when we're exercising in a hot situation, one of the primary things that we need to do is get rid of our heat. And the best way that we can do that is to maximize the amount of blood flow to the skin so that we can try to improve the amount of heat loss that we're seeing through evaporation, through sweating. So what's going to happen is as we exercise in a hot environment, we're going to see a lot of vasodilation of the blood vessels to the skin. This is going to significantly drop our total peripheral resistance. So we're going to have, as well as trying to supply blood to the large muscles of the leg, we're also trying to get rid of heat. So we're seeing a vascular bed in the skin, which is a very large vascular bed, decreasing its vasoconstriction or vasodilating. And so we'll see a significant decrease in total peripheral resistance. So if we need to maintain our blood pressure though, right? So obviously we need to maintain blood pressure. How are we going to react to that? Well, to some extent, we've kind of lost control of total peripheral resistance because we have this absolute requirement to get rid of heat, right? So this is taking over the control really of the vascular beds in the skin. So the only thing that we can really do now is start modifying our cardiac output. So we need to change our cardiac output. So this is going to mean that in a hot environment, while exercising in a hot environment, you'll see a really significant increase in heart rate and potentially an increase in stroke volume, or you would expect to see an increase in stroke volume initially, But then as more of the blood got stuck into the periphery, you might not see so much of a change there. But what this means is that for a given amount of exercise, the difference that you would see in someone exercising in a hot environment versus a cold environment is that that person exercising in the hot environment would have, on average, a higher heart rate to do that level of exercise and that level of activity in the hotter environment. So what this has an implication for is when you're actually looking at the way athletes are training and compensating and working in those environments. And so you can tend to do more work at a given heart rate in cooler environments than you can in hotter environments. This relationship between heart rate, stroke volume, total peripheral resistance also becomes really important when we're looking at, hemorrhages. Obviously, if we have a hemorrhage, we have a really significant decrease in total peripheral resistance in that the blood is actually leaving the system altogether. Obviously, there's going to have a really significant impact on stroke volume because we're not actually getting enough of the venous return. So our preload's going to be really down. So our stroke volume is going to be really low. And so as a result, the only lever that we have to play with now to try to maintain our blood pressure is heart rate. Okay, so our stroke volume will be lower, so we'll have a weaker pulse, and it will be very, very fast in a situation where we're dealing with some sort of hemorrhage. So I'm just sort of having a look here. So we have big muscles in the leg. So
we've been joking around. So
oh, okay. No, that's cool. I just want to make sure I hadn't missed a question or anything like that.
No.
So while I know that nobody asked for this, I was hoping that one of the things this really helps me with is every time you get a question related to, how does the sympathetic nervous system affect or influence blood pressure, or how would it change in a particular situation? If you can write down this formula, if you can look at this formula, and then you can look at these three levers that you have to play with and imagine how it is that those three levers are going to be changing in that situation, you can have a pretty good guess of how the cardiovascular system is going to respond to various different challenges that it's put under. Okay, so I see that we have a question real quick about, can we go over typical ECG trace and the representation of each deflection? Yep, that's very easy to do. And then I might pass it over to Jamie, and he can talk about the ovarian cycle, which looks like a good one. Okay, so really quickly, if we're looking at an ECG trace, okay, so your standard ECG trace, we're just looking at like a 4-lead ECG, can't remember 3 or 4 ECG. We have a wave here. We have a downward deflection, upward deflection, downward deflection. And then we have another wave here. That's not the greatest drawing of an ECG, but hopefully you get the idea. Okay, so the waves are labeled as such. So we have a P wave, we have Q, S complex, and we have a T wave. Okay. So last week we talked about this Wiggers diagram. We talked about the flow of blood through the heart, and we talked about the fact that, we have blood coming into the atria, and that mostly under the force of gravity, it just falls into the ventricle, but there is a contraction of the atria that squeezes a bit more blood into the ventricles. And this contraction of the atria requires depolarization, right? So if you remember the way the muscle contraction cycle works, you need depolarization of the muscle in order to get the calcium, and the calcium is going to be responsible for initiating the interaction between the actin and the myosin filaments and getting that contraction cycle to take place. So this P wave here represents the depolarization of the atria. Okay. That depolarization is going to spread through the heart and eventually infiltrate and cause the ventricles to depolarize. And so we'll see this QRS complex. And so this whole complex here represents ventricular depolarization. Now, the reason it has this QRS complex has to do with the fact that we're looking at a a three-dimensional structure in the heart, and we're looking at the way that the electrical activity is moving and rolling through the ventricle. Okay, so it's moving towards and away from the different electrodes and causing different deflections. So we see these sort of negative or downward deflections, and we see this larger positive deflection of the R complex. And so this relates to the movement of the electrical activity through that three-dimensional structure. And if you do a 12-lead ECG, then you get different images of this, and you'll get different deflections because you're picking up different movements of the electrical activity through that heart and different relationships between the different electrodes. At this point, though, we've got this ventricular depolarization, and we know that we need to actually cause this to repolarize. So we need this to relax, and we need the electrical activity to go back to cease, and for us to repolarize, to bring the muscle tissue back down to its resting membrane potential. So this T complex, or this T wave here, right, is actually ventricular repolarization. Right, so this is where the ventricular tissue is repolarizing, going back down to its resting membrane potential, somewhere around minus 70 millivolts or so, and getting ready for the next wave of depolarization to come through. Now, one thing that you may notice here is that we had an atrial depolarization as the P wave, but we didn't yet see, and we haven't seen, an atrial repolarization. Now, that's not because the atria doesn't repolarize. The atrial repolarization happens within this QRS complex, and so it tends to just be disguised and overpowered by this ventricular depolarization phase. So you don't see it in a normal ECG trace. So the question that I have for you here, and I think I can ask questions because it's quite a busy chat out there at the moment, is why are you interested? What is the significance? What's the importance of recording the electrical activity in the heart? Why might that have been something that we wanted to do? This is out there for you. I'll give you some thinking music. Well, I won't because I can't sing, but I'll give you a few minutes or a few seconds. Why do we want to record this? What's the significance of it? Okay, we don't know. Okay, so this is interesting. We're being asked to learn something about the ECG and what all these things mean, but what is it actually, why do we perform an ECG? What is it that it's actually telling us about? What it's telling us about is the electrical activity moving through the heart, right? So this is what this is telling us about. But the reason that we're interested in that is because it's the electrical activity that's driving the contraction of this cardiac structure, right? The cardiomyocytes. And so this gives us a proxy. It gives us a measure or a way of looking at the way that cardiac tissue is actually functioning, right? And if it's not functioning properly, then it's not contracting properly, which means that we're not pumping blood through the system properly. So what this electrical activity does is it gives us a non-invasive way of getting some idea of how the heart is functioning, and therefore some idea of how it is or isn't pumping blood effectively, right? So if you think about this was obviously developed well before MRIs and before echocardiograms and all these different things. This is a really good way to get a very easy and non-invasive understanding of what's actually happening inside the cardiovascular system, and particularly around the heart. Okay, I'm going to...
There was a question related to this. So user 479823 asked, during exercise when heart rate increases, which period on the ECG changes to increase the rate? Or does...
Right, okay. So we're looking at this here.
And so when you ask why would we want to trace the ECG, Skin says to identify any differences between individual beats. Average Joe says trace if the heart is beating normally with constant intervals. GTHA asked to detect the cardiac output and if it's had any problem in the heart, and Kylie says to detect irregularities in the heart.
Yeah, so all of those things are correct, and the reason that the ECG gives you a measure of those things is because it's really looking at the flow of electrical activity through the heart, and that electrical activity is connected, it is linked to the contraction, intimately and directly linked to the contraction of that cardiac tissue, and so therefore, yeah, it's going to impact how the heart is actually functioning, and so this gives you an indirect and external measure of how that's actually working. Okay, so when we're exercising, what are we actually going to be seeing here as a terms of an increase in heart rate? This is going to challenge me just a tiny little bit. We'll see how we go here. So if we're looking at that Wiggers diagram, the sorts of things that we're going to see when we're increasing heart rate is we're going to see an increase in the rate at which the atria are contracting initially, right? So the rate at which the SA node is driving the contraction, which is going to flow through the atria and then through the ventricles. So we'll see an increased rate of depolarization, so it will happen more quickly. But because of this increased rate of depolarization, what will happen is that you'll see that the gap between the ventricular depolarization, so this T here, and the next P wave will shorten, right? And so we'll see a shortening of the difference between the T wave and the P wave. What this is going to do, if we think about that Wiggers diagram, is it's going to reduce the isovolumetric relaxation phase, right? So we're going to see a reduced time during which the ventricle is relaxed and for blood to be able to flow into that ventricle before it starts to contract. So we're sort of looking at, this will be our T wave here. So this is T wave, this is P wave, right? And so our isovolumetric contraction phase is sort of within here. So what this means is that there's actually less opportunity, or potentially less opportunity, for the blood to flow into the ventricles. But this is somewhat compensated by the fact that you're breathing more heavily and inspiring more heavily. So you're going to increase a little bit of negative pressure inside the thoracic cavity. That's going to help draw the blood back into the atria and into the ventricles. You'll also see an increase in the contractility of the ventricular tissues, which is driven by sympathetic nervous system activation. And so you'll be able to maintain, if not actually most likely increase, your stroke volume, even with an increase in heart rate. So this gap here is likely to change. We'll also see, as I said, you may actually also see a little bit of a shortening of the gap between the P and the QRS complex, right? So if this is our QRS complex here, you might see a decrease in that gap here. And that's, again, driven by the sympathetic nervous system activation, which is going to increase the speed of conduction of the electrical activity, particularly through the AV node, right? So particularly at that transition point between the atria and the ventricles, you'll see a speeding up of the conduction. And so you might see, depending on the amount of exercise and how activated the sympathetic nervous system is, you might see a reduction in the PQ interval as well. I can't think that there's any other, I don't believe that there is any significant change in the QRST complex. I can't imagine so, in the speed of the repolarization of the ventricle tissue. But certainly this one you may see depending on the level of sympathetic nervous system activation, but certainly difference between the T wave and the P wave would be most likely where you would see that difference.
Just quickly, does standing up increase diastolic blood pressure or systolic blood pressure?
Does standing up increase diastolic blood pressure or systolic blood pressure? So initially you would see a decrease in systolic blood pressure, and you may see a slight increase in diastolic blood pressure. based on the fact that you would see a flow that would be heading back towards the left ventricle, and so therefore you might expect to see a little bit higher aortic pressure. But the reflex response to that is so quick that you probably wouldn't see any marked change in either of them over any length of time, I wouldn't imagine. But maybe Amanda can help me with some of that. This is sort of a little bit outside of my wheelhouse at the moment. Cool.
So, Skeen, if you want to read that, just double checking, I think, on what you just
Both increase the heart rate needs to beat harder, increasing systolic pressure, and the atrial diastolic pressure needs to increase to allow for more blood to enter the heart. I think that's right. So both increase the heart needs to beat harder, increasing systolic blood pressure, and the atrial diastolic pressure needs to increase to allow more blood flow to enter the heart. So certainly you would see an increase in heart rate. As I said, that would be as a way of sort of counteracting a slight shift in the systolic blood pressure. And so that increase in heart rate is a reflex response. It would help to sort of maintain your blood pressure as you move from a laying down to a standing up position. The atrial diastolic pressure, I'm not quite sure, that might be the aortic diastolic pressure, needs to increase to allow for more blood flow to enter the heart. I'm not quite sure what that actually is trying to say there. So Skeen, if you feel that you can clarify that would be good. So yeah, I think that's probably where we're at.
Yep.
You ready to get going on? There was another question about reproductive stuff.
Yep.
Excellent.
While we finish off, so this will be the last question we'll have time to do. We do have families to get home to as well, so I'm sure everyone wants to get on, have some dinner and everything. All right, so I got asked about the relationship between the ovarian cycle and the uterine cycle. And we know that this is a little bit artificial because while the normal menstrual cycle occurs over a 28-day period, in fact, the ovarian cycle occurs over a much longer period. In fact, it takes almost a year for a primordial follicle to eventually become the ovulated follicle. But we sort of simplified into that sort of typical 28-day cycle. So the normal menstrual cycle. So if we've got day 1 here, in the middle, of course, we have day 14. If we think about the ovarian cycle has sort of three broad phases, I suppose. We have the part that's being captured by FSH, and the first part, which basically runs from day 1 to about day 13, we call the follicular phase. And so this is where FSH is capturing our already developing follicle and causing that dominant follicle to be selected and to actually begin to develop and become the dominant follicle that will eventually become ovulated. So as this dominant follicle is growing and being captured during this phase, it begins to pump out lots of estrogen, which we'll call E2. Okay, so the follicular phase is capturing of the follicle, secondary follicle, causing it to become one of them to become a dominant follicle, and as that does so, it's producing more and more estrogen. Now, normally what happens is the moderate levels of estrogen actually has an inhibitory effect on FSH, so that begins to decline. But there gets to a point around about day 12 of the menstrual cycle where estrogen peaks. So we reach this sort of peak of estrogen around about day 12, and this has a positive effect. So from here to here, we have a sort of an inhibitory effect of estrogen on FSH. And LH secretion through GnRH, through the hypothalamus. And then it reaches a peak around, estrogen reaches a peak around day 12, and then that actually has a positive effect on FSH and LH secretion. So on day 13, we actually get this peak in LH, and then on day 14, we actually get ovulation taking place. We get rupture, so ovulation takes place on day 14. what happens then? Yep. So we'll get to the uterine cycle in a second. Spaghetti bolognese. It's a bit odd to say, isn't it? Spag bol. So what happens then after ovulation? The remnant follicle of this dominant follicle actually converts and transforms and then drives the second half of the third part of the phase. I suppose if we think follicular being the first, ovulation being the second, then the third part is known as the luteal phase, and that's because of the formation of the corpus luteum. And so this is a little oops. Sorry. So the corpus luteum forms, and that begins to pump out estrogen, but also primarily progesterone. Okay, so the luteal phase is formation of the corpus luteum from that remnant dominant follicle within the ovary after ovulation, and it pumps out predominantly progesterone but also some estrogen. So here's our three phases of ovarian cycle. We've got the follicular phase from day 1 to day 14, ovulation taking place on day 14, and then the luteal phase from day 14 until day 28. If no fertilization takes place, then this degenerates. At this time we lose our progesterone, which we lose our stimulation for our endometrium, which we're about to talk about here. So if we've done the ovarian phase, then we sort of can divide this into now our uterine cycle or our menstrual cycle. So this was the ovarian cycle up here. So the uterine cycle is also divided into three phases, but three slightly different phases. So here, if we have day 5, the first part of the uterine or menstrual cycle is known as the menses, or the menstrual phase. So again, it's a sort of if we think about the menstrual cycle being a continuation, it's occurring because of the previous cycle. So in the previous cycle, what happened was there was no fertilization, so the corpus luteum degenerated, we lost our progesterone, and therefore we lost our maintenance of the endometrial lining. So we get vasoconstriction of the blood vessels, and we get ischemia happening, and we actually shed that endometrial lining. So if we sort of think about our blood vessels here, we actually lose that lining right back to the stratum basale. So if we sort of think about stratum functionalis and the stratum basale being the two layers there. So then what happens is from menses, from day 1 to day 5, the woman loses, or the person with the uterus loses their endometrial lining, the stratum functionalis, leaving behind the stratum basale. So now we've got our capture in the follicular cycle of our dominant follicle, and it's beginning to put out estrogen. Now estrogen actually helps to regrow the stratum functionalis from the stratum basale. So we actually begin to see the glands reforming and the endometrial lining reforming. Okay, so if we sort of think about the stratum functionalis here and the stratum basale being down here. So we get regrowth. So from day 5 to day 14, this is known as the proliferative phase. Okay, so what's occurring in the follicular phase occurs both the menses phase and the proliferative phase within the uterine cycle or the menstrual cycle. So this proliferative phase is being driven by these increasing levels of estrogen, which is causing regrowth and redevelopment of the stratum functionalis from the stratum basale. So our endometrial glands grow, our epithelium regrows, and we begin to get our spiral arterioles in this region beginning to grow and fill these spaces. So ovulation takes place on day 14. Then we get the luteal phase of the menstrual cycle. So we're getting lots of estrogen and lots of progesterone. So progesterone and estrogen are driving these further changes within these glands. And so this part of the menstrual cycle is known as the secretory phase, because the uterus is preparing for implantation to take place. The glands begin to secrete material to support the developing embryo as it begins to implant. So we actually get increase in size, increase in complexity of the glands within there, and then we actually begin to lose it all again if fertilization doesn't take place. So do you refer to both the ovarian and uterine cycles as the menstrual cycle? No, they're actually separate. So the uterine cycle is specifically menses, proliferative and secretory phases. Ovarian cycle is follicular, ovulation and luteal. Now we can actually sort of encompass these terms into what we call pre-ovulatory and post-ovulatory phases. So the pre-ovulatory phases include menses, proliferative and follicular phases. And then the post-ovulatory phases in the ovarian cycle is the luteal phase, and in the uterine cycle is the secretory phase. So here, as we were talking about, we've got our endometrium, we've got the stratum basale here, we've got the stratum functionalis, and within these we've actually got our spiral arterioles arising from our basal blood vessels here. So here's our spiral arterioles connecting to our basal. And so what happens is when we don't get fertilization taking place and we get our withdrawal of our progesterone, we actually get vasoconstriction taking place within these blood vessels, which means that all this tissue of the stratum functionalis loses its blood supply, undergoes ischemia, and it begins to be shed, and we move back to our next menstrual cycle. So does that sort of cover what you are asking me to cover? So we've got our ovarian cycle up here. The hormones from the ovarian cycle are driving the changes within the uterine cycle, the menstrual cycle. So they overlap, obviously, and it's the hormones produced by the ovarian components which are driving the menstrual cycle. And of course, what's driving the follicular cycle or the ovarian cycle are the gonadotrophins, so FSH and LH and so on. Happy chappy is a happy chappy, which is good. And I'm a happy chappy that you're a happy chappy. So we're all happy chappies around the place. We are obviously very male dominated here, so there's lots of chaps around the place. All right, well, it's about 11 past 6, so it's a little bit over our time there. Hopefully you found that useful. As I say, we'll be back on Thursday, 4 to 5 p.m. The recordings will be there if you can't make that time. If you want a question answered during that time, please go to our Milo page or and ask your question on the discussion forum. We actually now have a little area there where you can ask your questions. But also, if you want to email me, or you also have the opportunity for those of you who aren't a UTAS student to ask a question on Twitter. I'm at Chapman_histo. James is at Dr. James Crane, and you can follow us on Twitter. He's going to type that out in the chat there. So thanks very much for coming along. As I say, I hope you found that useful. For our UTAS students, very best of luck for Wednesday and Tuesday's exam. So I know Launceston students have their exam on Tuesday. Our students here in Hobart have it on Wednesday. But thank you very much, Jamie, James, and from Anne-Marie. You're very welcome. I'm glad you found it helpful. Thanks very much for coming along, and we hope you come to our future streams. So it's bye from me, it's bye from James.
Bye everyone.
And we'll see you in the next stream. All right, hooroo.